Good evening, ladies and gentlemen. I am Dr. Niroshan Lakunarangode. On behalf of Ceylon College of Physicians, I warmly welcome you to the 5th lecture of Cutting Edge Lecture Series with international faculty. May I invite the President of Ceylon College of Physicians, Prof. Arosha Disanayake, to speak a few words. Over to you, sir.
Thank you, Niroshan. My name is Arosha Disanayake. I'm the President of the Ceylon College of Physicians. I warmly welcome all the participants who have joined this online lecture. Now, as you all may be familiar by now, we have divided each month of the year into a specialty, and the month of July is our rheumatology month. We've already had two very important activities. We've had the college lecture, which was done for the beginning of this month. And then yesterday we had the specialty update with 4 rheumatologists participating, an excellent forum. And then, of course, perhaps the highlight of all, where we call this the Cutting Edge series, where we invite a resource person from a center of excellence who has done important work in novel developments in that particular field to share cutting edge knowledge with us. This is the 5th in this series, and today it is my great pleasure to welcome Dr. Stober, Dr. Caspar Stober from Cambridge, UK, to share her expertise with us. I'm sure all of us will learn a lot in her talk, which revolves around where we are in terms of having precision medicine for psoriatic arthritis. A warm welcome to Dr. Stober also from us. And then I'm very grateful to Dr. Niroshan Lakunarangode, who always does an excellent job in coordinating this activity. He's in charge of that. He's the lead of the CCP for the Cutting Edge series. Then, of course, the president of the College of Rheumatologists and Rehabilitation Specialists, Dr. my friend, Dr. Biminda Singha. He will be chairing today's session, and he will be introducing the speaker to you as well as directing the talk. Then the CCP is well represented by rheumatologists this year. We have 4 rheumatologists. We have 5 rheumatologists at the CCP Council. Actually, you all might know the president-elect for 2023 is a rheumatologist, Dr. Biminda. So there is Dr. Anushka, Dr. Chaturika, Dr. Himant. They're all helping us with this program. So at the end, in the Q&A session, Dr. Chaturika will take over and direct all the questions to Dr. Stober. We have the questions on the Q&A thing. You can type your questions on the Q&A, and then we will direct them to Dr. Stober. Dr. Chaturika will handle that. Then, of course, finally, Dr. Niroshan will take over for the vote of time. So that's the outline of today's program. I hope all of you will benefit enormously. If you have missed any of the previous programs that I spoke about, they are available on the CCP YouTube channel, as well as we will have the rheumatology quiz, and then that will be award prizes as well. So over to you, Dr. Biminda Singha. He's the president of the College of Rheumatologists and Rehabilitation Specialists. So over to Biminda to take over from now on, introduce the speaker, and then proceed with the talk for today. Thank you very much. Have a very pleasant and a productive evening. Thank you.
Thank you, Arosha. It's a privilege and a pleasure for me to introduce the speaker. Dr. Caspar Stober is a consultant in rheumatology based at Cambridge University Hospital, UK. She undertook academic clinical training in Cambridge and was a National Institute for Health Research supported clinical lecturer. Her specific research interest was the evaluation of metabolic factors influencing Th17 associated T cell expansion in psoriatic arthropathy. Dr. Stober co-established a psoriatic arthritis clinical service in Cambridge to provide a quality service evaluating several components of disease and also prompts to facilitate composite disease activity measures and thus improve patient outcomes. Dr. Stober is a member of the GRAPPA Research Collaboration Network, where she has co-organized and co-organized proceedings, in addition to being involved in international research initiatives. Dr. Stober has special interest in lung disease associated with connective tissue diseases and rheumatoid arthritis, where she has also been a co-investigator in several clinical trials. Dr. Carmel Stober has a PhD in immunology from University of Birmingham. Quite interestingly, her supervisor was Dr. Duminikantha Maratna, and her postdoctoral research at the University of Cambridge, in collaboration with the Wellcome Sanger Institute, evaluated DNA and viral vaccines in leishmaniasis. This provided opportunities to collaborate with the researchers in Brazil, India, and Sudan. Dr. Stober has preclinical experience of using notch antagonists in multiple sclerosis and arthritis and anti-IgE antibodies in asthma. Her research has been presented at international meetings and published in several peer-reviewed journals. Dr. Carmel Stober is going to talk to us today on where are we with precision medicine in psoriatic arthritis. Over to you, Dr. Stober.
Many thanks for that kind introduction. So I'm hopefully going to be able to open up my presentation. Is that okay? Can we see the first slide? Okay, great. So it's a great pleasure for me to be able to provide this lecture to you today, and I'm most grateful for the introduction. As has already been described, I'm currently mainly a clinical rheumatologist, where my subspecialist interest, or one of them, is psoriatic arthritis. And you'll see that in my title, I've talked about psoriatic disease because in addition to arthritis, psoriasis associated manifestations are multiple. We're going to talk about precision medicine, which I have to be honest with you, we're only early on in trying to use precision medicine in this disease area. So the overview of what I'm going to talk to you today about is as follows. I'm going to talk about the musculoskeletal and also the non-musculoskeletal features of psoriatic disease and associated comorbid conditions that we need to take into consideration. We'll focus on evaluation of how disease activity is measured. So that's individual components as well as composite measures, and in particular response criteria, taking into consideration guidance from both GRAPPA and also EULAR, and the management of the patient with psoriatic disease. So we'll look at articular and non-articular MSK features and non-musculoskeletal manifestations. This nomenclature has recently been established from international organizations, and I'll break that down in more detail. We'll look at comorbid conditions, a little bit on prognostic factors and also patient factors when deciding upon treatment. So I thought I'd start off with a case. A gentleman who is 58 years old, who works as a refuse collector. And when I met him in 2016, he was working full time. He had had psoriasis since the age of 17, where management had predominantly been topical treatment, light therapy, and there had been a brief trial of the DMARD methotrexate, but he had failed to tolerate this because it had caused nausea. He developed joint problems in his 40s, where he described difficulty moving his neck, reduced dexterity of his hands, swelling of the ankles. His work as a refuse collector had become increasingly more difficult, and he was struggling to get out of the bath. He'd had documented uveitis and scleritis, non-alcoholic fatty liver disease. He was a diabetic, hypertensive with hypercholesterolemia, and he also smoked 10 to 15 cigarettes per day and drank alcohol rarely. So initial evaluation in the rheumatology clinic of this gentleman, we initially focused on the articular musculoskeletal manifestations, which I'll touch on in more detail. So in psoriatic arthritis, we perform a tender and swollen joint count of 68 and 66 joints in contrast to what is normally performed in rheumatoid arthritis. Non-articular musculoskeletal manifestations include dactylitis, which is sausage digits, enthesitis, we'll talk about that in more detail, which is obviously inflammation of tendon attachment sites. And then we can also obviously evaluate axial disease. So looking at components such as lateral flexion, rotation of the cervical spine, and then clinical measures such as modified Schober's test. In terms of activity scores for axial disease, BASDAI is what is often used. And again, we'll focus on that in more detail. And the predominant non-musculoskeletal feature that we think about in psoriatic disease is psoriasis. And in this case, this gentleman had quite extensive psoriasis with a body surface area of more than 10%. And the subtype of psoriasis was erythrodermic psoriasis. And he also had nail involvement. I described comorbid conditions of increased body mass index, hypertension, diabetes, hypercholesterolemia, and the Q risk 3 score, which is a cardiovascular assessment risk, was 40%, which is quite significantly elevated. In terms of blood tests, his rheumatoid factor was negative, as was his ACBAR or anti-CCP, which are tests for rheumatoid arthritis. He was ANA negative. He was HLA-B27 positive. Uric acid was in the normal range, and he had elevated acute phase markers when we first met him. And preliminary plain radiographs, the image here on the left was actually taken before I met him. Unfortunately, this radiograph had been reported just focusing on the vertebral bodies, where it was described as showing mild degenerative change. But actually, what we can see here was that there was complete fusion of the posterior elements. And by the time I met him, this had progressed. Clearly, he wasn't able to really move his cervical spine. He also had a plain film of his pelvis, and this demonstrated bilateral grade 4 sacroiliitis, and also hand and foot radiographs. And I'd like to focus your attention here on quite prominent new bone formation, juxta-articular new bone formation evident in the hands. He's got distal interphalangeal joint involvement with some juxta-articular new bone formation. And in the feet, we can see very severe disease where there is osteolysis, so loss of bone here. Often one refers to penciling cup, which is a feature of osteolysis. And here we can see ankylosis of, several different portions of his feet, including the first MTPJ. So thinking about our case and how are we going to move forwards, I thought I'd introduce to you the Caspar criteria for classifying psoriatic arthritis, which was developed by an international group of individuals looking at both prospective clinical and radiological data from 1,200 patients either with psoriatic arthritis or non-psoriatic arthropathy. And the distinguishing features are as follows. So an individual fulfills Caspar criteria if they've got peripheral, axial, or enthesial involvement with more than 3 of the following. So a family history of psoriasis is sufficient. Nail dystrophy gives you a score of 1, a negative rheumatoid factor via an ELISA method or nephrolometry, dactylitis, which is the soft tissue swelling of the fingers or toes, and then radiological evidence of juxta-articular new bone. And we have our specificity and sensitivity values here. Now, interestingly, our gentleman would also fulfill ASAS criteria for spondyloarthritis. That is based upon the fact that he is HLA-B27 positive and has sacroiliitis on imaging, with several features demonstrated in this left panel here. If we think about the impact of psoriatic arthritis, now I've used the word here psoriatic arthritis, but I think we should think broadly about psoriatic disease, given the modalities or the domains, as we now refer to them, that are involved in psoriatic disease. The prevalence of psoriatic arthritis in the population is 0.17 to 0.42%. And approximately, it's predicted approximately 15 to 25% of patients with skin psoriasis will go on to develop psoriatic arthritis. The age of onset is between 25 to 50 years of age, so a bit younger than our rheumatoid cohorts, and the gender distribution is similar. Patients have articular and non-articular musculoskeletal manifestations, as well as our non-musculoskeletal manifestations, and there is a range of disease burden, which I've summarized, well, which has been summarized in this flow diagram here. So when we think about evaluating our patients, OMERACT is an international organization which prioritizes some of the features that patients are concerned about. Fatigue always comes out as being quite a dominant feature that patients describe as being problematic for them. Obviously, stiffness and functional problems, difficulty working, work participation is something that's now looked at as a BSR outcome measure in arthritis, in particular psoriatic disease. And obviously, psychosocial problems, partly to do with, for example, the appearance of skin psoriasis. So psoriatic arthritis as a phenomena distinct from rheumatoid arthritis was originally described by Moll and Wright in the 1970s. And at that time, we looked at different subsets of articular disease. So I think the feeling now is that there is some overlap. However, I thought it was useful to show this to you today. So approximately 5 to 20% of patients can just have distal interphalangeal joint involvement, and that's strongly associated with nail disease. A monoarticular or oligoarticular pattern involving 1 to 4 joints is very common and is probably the most common subtype of psoriatic arthritis that we see. A rheumatoid pattern of symmetrical polyarthritis, this subset of patient is the one that normally would get enrolled to clinical trials, although it's not the most common subtype that we see. And I guess it is probably more common to see lower limb involvement in the patient cohorts that we see, probably related to biomechanical stress being a trigger. Our patient that I've described to you today has a rarer subtype of psoriatic arthritis, and that's psoriatic arthritis mutilans, where there's the severe destruction of fingers and toes with telescoping, as is depicted here in this picture, and with the bone loss or osteolysis. And in here, we also talk about the extra, well, the non-articular musculoskeletal manifestations, so axial disease, enthesitis, so affecting tendon attachment sites, and then the dactylitic component, which is thought to probably be a type of enthesitis based upon inflammation of the pulleys, resulting in soft tissue swelling and enthesitis. And in this table at the bottom here, I've summarized the prevalence of the different components within patient cohorts. So often by definition, most patients have psoriasis, peripheral joint involvement in a high proportion of patients, and then nail disease in approximately 50%, axial disease in 25 to 40%, enthesitis. Enthesitis is possibly thought to be the lesion that starts the whole process going. Dactylitis, the prevalence is quite variable. Uveitis, compared to, for example, spondyloarthritis or axial spondyloarthritis, is less frequently seen, as is inflammatory bowel disease, but comorbid cardiovascular disease and also depression is very common. So how do we assess a patient with psoriatic disease? Psoriasis, there are probably two different genetic predispositions for psoriasis. An early onset, there are particular HLA-C genes associated with an early onset of psoriasis, and then a later onset of psoriasis in those over 50 certainly has more of an association with metabolic syndrome. Most commonly, we see chronic plaque psoriasis that can affect different locations, scalp. Palmoplantar psoriasis is probably genetically a subset of itself. And when we describe plaques, we can think about them as being small or large, thin or thick, and then with or without nail involvement. So this is guttate psoriasis, chronic plaque psoriasis, scalp psoriasis, nail involvement with pitting and onycholysis. Psoriasis is much more complicated than that, in that there are subtypes within the chronic plaque category. And I guess probably as rheumatologists, we're perhaps less good at evaluating and managing these more subtle subtypes. So flexural psoriasis, seborrheic dermatitis and psoriasis overlap. I think this is often quite a challenging subset. I've mentioned palmoplantar, which is probably genetically a different type of psoriasis. Interestingly, it's the type that potentially people can get paradoxically with anti-TNF therapy. Erythrodermic psoriasis is quite uncommon, but my patient did have this subset of sort of quite aggressive, widespread psoriasis. And clinically evaluating psoriasis within the rheumatology clinic, we most probably would use body surface area. And what one uses the surface area of it's supposed to be the palm of the patient's hand to determine how much of the body surface area is affected. So one palm is 1% of body surface area, and then we can categorize into mild, moderate, or severe. For the point of view of utilizing biologic therapies or advanced therapies, however, PASI is required, which is a psoriasis area and severity index, which divides the body into distinct regions and then looks at three features: erythema, induration, and scaling. And that's then the severity of that is evaluated. And then a composite score can be achieved, which is between 0 and 72. And within the UK, the threshold for biologic use is a PASI of 10. In terms of treatment response versus baseline, we talk about PASI 75, 90, or 100. So this is the percentage improvement from the baseline. Articular evaluation in psoriatic arthritis. So I mentioned about the fact that we actually look at 66 and 68 joint counts, which are summarized in this figure here, compared to rheumatoid arthritis, which doesn't look at distal interphalangeal joints and doesn't evaluate feet. Hence the differences that we get in terms of outcome measures. And this type of algorithm would be used in all of the different composite measures that I'm going to be describing to you today. So this would be a standard measure of tender or swollen joint counts. Obviously within swollen, we don't look at hips, and that's the main difference between the swollen and tender evaluation. Now, if we consider non-articular manifestations of psoriatic arthritis, then axial disease or psoriatic spondyloarthritis has been recognized as probably occurring relatively frequently in psoriatic arthritis, although it's not something that people often complain about. So one has to really ask the patient about this manifestation. And I've just summarized here what the difference is between psoriatic spondyloarthritis and what is traditionally thought of as axial spondyloarthritis or ankylosing spondylitis. So the main differences that we see are that this tends to be a relatively late presentation in psoriatic disease. It tends to involve the cervical spine much more so than in ankylosing spondylitis. Quite often there is no, if there is sacroiliitis, it's not necessarily symmetrical, which is a typical feature of ankylosing spondylitis. And then the type of bone formation that one sees in the spine is quite different. So the vertical syndesmophytes, possible bamboo spine are what is observed in ankylosing spondylitis. However, in psoriatic spondyloarthritis or axial psoriatic disease, we often see these quite bulky paramarginal syndesmophytes, which morphologically are very distinct. Obviously, in terms of screening, we would ask similar questions, ask about buttock pain, inflammatory features, so pain and stiffness, worse in the morning, waking people up, worse at rest, improve with activity, improve with non-steroidals, and obviously going on for more than 6 weeks. And then we'd obviously look at restricted neck movements. Approximately 25% of patients are asymptomatic, and so we're only picking this up with imaging. So it might be something you might do in your routine practice, is get plain films to evaluate this. I mentioned to you before about how do we assess axial disease. So in ankylosing spondylitis or axial spondyloarthritis in the UK, we use BASDAI, which is the Bath Ankylosing Spondylitis Disease Activity Index. And this would be performed using a numerical rating score. And how that's performed is summarized here. So they're quite subjective measures, asking the patient to rate symptoms over the past week, and then that comes up with a score. Biologic entry for ankylosing spondylitis requires this to be 4 or more. Now, probably more globally across Europe, and there's a move towards this in the UK, we use something called the ASDAS score. So it's Ankylosing Spondylitis Disease Activity Score. And in addition to the questions, some of the questions used in the BASDAI, we look at acute phase markers as well. And on doing so, we're then able to clarify whether somebody is in active disease, moderate, high, or very high disease activity using established cutoffs. I wanted to mention to you a study that has been, is ongoing. The reference here is at the bottom. So it's only just starting to recruit. And this is called the AXIS study. It's a study originated by an organization called GRAPPA. And that is because really we don't know very much about axial disease in psoriatic arthritis. So there are 3 objectives here to determine the frequency of axial involvement, the frequency of active inflammation and structural change on imaging, suggestive of inflammatory involvement. So this will be using plain film as well as MRI scanning. And then in addition to that, to identify clinical laboratory and imaging features associated with the presence of axial involvement in psoriatic arthritis. So this is going to be let me just move this, a multinational, multi-center, cross-sectional study that's going to be undertaken, or has just started. That is recruiting globally. Hold on a minute, I've frozen. Aha. Okay, let me just move that back. Okay, all right. So I'd mentioned to you enthesitis. So this is inflammation associated with tendon attachment sites. Now, basically, there are a number of different ways in which this can be assessed. And on the models that we've got here, the red dots represent tendon attachment sites that can be assessed. And I guess the ones that we commonly look at day to day in our patient cohorts are the Achilles insertion, the lateral epicondyle, and the medial femoral condyle. And essentially, this is obviously just a palpation of an enthesial site. Often in clinical practice, this might be difficult to differentiate from something like a myofascial tender site. And if I just move on to the next slide here, just a moment. Okay. As part of most of the composite measures that I'm going to describe to you, we use something called the Leeds Enthesitis Index, a measure that was developed at the University of Leeds, which is a dichotomous scoring system of 6 enthesial sites, as mentioned: Achilles tendon, lateral epicondyle, and medial femoral condyle. A more comprehensive system is the MACES, or the Maastricht Ankylosing Spondylitis Enthesitis score. This is mainly used in clinical trials rather than routine clinical practice. Dactylitis, the most common way in which that may be assessed, is the Leeds Dactylitis Index, which is quantitative definition of dactylitis, where there's a 10% increase in circumference compared to a non-affected digit, and how tender the digits are as well. This isn't something that we would normally do in routine clinical practice. So certainly within recommendations from GRAPPA as well as EULAR, there is a recommendation for composite measures and evaluating multiple domains of psoriatic disease in an individual patient to achieve an outcome which targets the most significant lesion in that patient. Within the UK, the component that we currently still use, which is only really a response criteria and not actually a measure of activity or response to treatment. Well, sorry, it is a measure of response to treatment, but not a disease activity measure or a treat to target measure, is what's called the PSA response criteria, or PSARC. And that's a 68-66 joint count with a patient self-assessment and a physician's assessment of disease activity using a Likert scale. And then we have a response criteria attached to that in terms of assessing biologic efficacy. However, just a moment. Here we are. There are now multiple different composite measures that are being evaluated by a variety of organizations. And the couple that I think I pointed out to you as being the ones probably most important for use in routine clinical practice in the near future are, hold on a minute, minimal disease activity and also something called the DAPSA. Now, minimal disease, here we can see in red and green what components are measured in the different composite scores. So acute phase markers are measured in DAPSA, but not minimal disease activity. All of the measures look at tender and swollen joints. There are a number of global and pain assessments. Non-articular inflammatory musculoskeletal manifestations are looked at in several of the measures, including enthesitis and dactylitis. Health-related quality or functional assessment only in some, and skin is not taken into account in the DAPSA, but it is in the other measures. And so in terms of which is the correct measure to use, so currently this is the measure we use in the UK. However, it's only a measure of response to treatment. It only looks at the articular component, and there's no acute phase marker. Minimal disease activity is a treat to target measure. So similar to treat to target in rheumatoid, it's what we should be aiming for in our patient cohorts. There is a similar algorithm, low disease activity, which is a less stringent measure. There is no acute phase, no axial disease, and it's a measure of disease state. The DAPSA is a treat to target measure as well. It doesn't include skin, enthesitis, or axial disease, and it's a response measure as well as a cutoff for disease state. These two measures are quite comprehensive and probably in the challenge of a day-to-day clinical practice are quite difficult to achieve, but perhaps that's what we should be moving towards. PAS-DAS and CP-DI measure disease activity, response, as well as disease state. And I thought I'd include minimal disease activity and what it's looked at. This is advocated by GRAPPA, which is an international organization for research and assessment of psoriasis and psoriatic arthritis. So here we look at tender and swollen joints, and the aim is to have less than or equal to one of these. PASI or body surface area for skin. There are a number of functional and pain assessments. And then there's also the Leeds Enthesitis Index here. In terms of comorbid conditions in psoriatic disease, I've already mentioned that there are several that we also should take into account when we look at our patients and our outcomes and improving our outcome measures, with a view that probably psoriatic arthritis in the older cohort or the cohort over 50 is likely to be partly not just an inflammatory disease, but a metabolic disease itself. So metabolic syndrome is highly prevalent in our patients with psoriatic arthritis. They are known to have increased cardiovascular mortality and morbidity, increased risk of hypertension and heart failure, and all of these components are more common in our patients and are something that we should be certainly working with our primary healthcare physicians to manage. Inflammatory bowel disease and uveitis are present, but are less common than typically ankylosing spondylitis. And osteoporosis is something also that patients are at risk of, especially if we're using steroids in our patients. So in terms of what we should be doing in our day-to-day clinical practice, we should be thinking about body mass index, looking at waist to hip circumference. Obviously, we should be looking at measures such as Q risk, non-fasting lipids, HbA1c, thinking about kidney disease, lifestyle advice, social issues, depression and anxiety, potentially inflammatory bowel disease screening, and also uveitis if that is an issue, and FRAX assessment and bone density scanning in addition to that. So I thought I'd move on to treatment recommendations, and I focused today on GRAPPA, an organisation that I'm proud to be part of, and it's something that if people are interested in doing, they only have to be proposed by 2 current GRAPPA members in order to join this organisation, and there are opportunities also to attend international meetings if people submit abstracts to the meeting. So it was just recently took place in New York, and next year it's going to be in Dublin. So a little bit here on the mechanistic or the important cytokines which are involved in the etiology of psoriatic disease. So I guess where we have come to this is an interplay of genetics as well as basic science and mouse models, and that we know that the upstream cytokine that seems to drive disease is interleukin 23, which according to the site that you look at is produced mainly by innate immune cells such as a dendritic cell, and what stimulates them to produce that cytokine is probably multiple different agents. We know things like microbiota are important. Biomechanical stress is another factor. And I guess it's an expanding area looking at factors which perpetuate the production of IL-23. I also mentioned metabolic syndrome. IL-23 drives the differentiation of naive T cells down the T helper 17 pathway, and cytokines produced by type 17 cells of CD4 or CD8 include IL-17 itself, IL-22, and also TNF. TNF's obviously produced by innate cells such as macrophages, as well as T cells of the T helper 1 subtype, as well as the T helper 17 subtype. But what differentiates psoriatic disease from, for example, rheumatoid arthritis is the importance of the entheses. And it's thought that the innate cells that produce IL-17 and IL-23 are resident in the area of the tendon attachment sites. And many of the studies by internationally, in particular by Dennis McConigal in Leeds, where he's actually identified innate cells producing IL-23 in the spine of patients, as well as there's quite a lot of murine studies identifying subsets as well. IL-22 is a cytokine which is thought to be important in driving new bone formation and the expansion of osteoblasts. And IL-17 probably plays a role here as well. So I've focused here on different lymphocyte subsets, innate immune cells, as well as cells of the, so osteoclasts and osteoblasts, osteoclasts driving the osteolysis process, and osteoblasts driving new bone formation, which is unique compared to rheumatoid arthritis. This is a very busy slide, but essentially looks at the overarching principles as recommended by GRAPPA in the most recent guidance from 2021. So I wanted to focus the attention here on the goal of therapy in patients with psoriatic arthritis. So one wishes to achieve the lowest possible level of disease activity in all domains of disease, and then to define what is remission or low or minimal disease activity, which is acceptable, and that's for the patient as well as the physician, to optimize functional status, improve quality of life and well-being, and prevent structural damage to the greatest extent, and to minimize complications both from untreated active disease and from therapy. Obviously, in a country like Sri Lanka, one has to think about infectious disease in optimizing treatment to different patient cohorts. But I've included this, and I'd focus your attention here where the guidance talks about the domains, it talks about imaging, as well as comorbidities and how they're important in treatment decisions. EULAR has similar recommendations. Their guidance is slightly older, and so it means there's probably going to be a gap between these recommendations of a couple of years or so. And here it also talks about defining a target, and it mentions specifically here the DAPSA that I've talked about, or minimal disease activity. And of the fact that we need to take into account comorbid conditions, patient factors, and drug-related risks. This is the GRAPPA guidance for active psoriatic arthritis 2021. And what we can see here is that psoriatic arthritis or psoriatic disease has been divided into the domains that I've discussed with you today. So skin disease, peripheral arthritis, axial, enthesitis, dactylitis, nail disease, and then it also looks at inflammatory bowel disease and uveitis. And I guess what I wanted to point out, possibly where there is a difference, and we think now about precision medicine. So anti-TNF therapies in general tend to work for all of the domains of disease. However, IL-17 inhibitors are avoided in the setting of inflammatory bowel disease, whereas IL-23 inhibitors, which is obviously an upstream molecule, the suggestion is that they don't work in axial disease. So there are some differences between what choices would be made in axial versus peripheral disease, taking into account domains, and also into account the severity of disease that people have. Upstream here, we look at things like non-steroidals, physiotherapy, local injections. Synthetic DMARDs such as methotrexate are used for peripheral disease. There isn't a huge amount of evidence that they're beneficial in enthesitis. Methotrexate has some efficacy. A drug called Primilast, which is a phosphodiesterase 4 inhibitor, relatively, well, it's a safe medication, but doesn't have very good efficacy in general. We don't tend to use it very much in the UK. Here we can see it talks about comorbid conditions and how one should reevaluate disease activity using a validated outcome measure. So that's where I just wanted to compare and contrast two different entities or domains. This is the EULAR guidance, slightly different management algorithm here, taking into account polyarticular or monoarticular disease, local treatment, and then first line synthetic DMARDs before moving on. Enthesitis, it talks about moving either from a non-steroidal straight to a targeted therapy, biologic therapy, as we can see here in the phase 3 of the algorithm. Here it divides again up into, so at the bottom it talks about outcome measures, about going through the cycle and how long you should try a particular treatment for before you decide that it's failed. So subtly different, but I guess the broad brush is similar. This table takes into account comorbidities. A couple of examples here, which I guess are useful. So obviously anti-TNF therapy is avoided in the setting of demyelinating disease and congestive heart failure. Obviously in terms of infection, there are probably most of the biologics should be used with caution. And fatty liver disease, obviously we'd want to avoid using synthetic DMARDs such as methotrexate and leflunomide. Non-steroidals, obviously cardiovascular disease. So if we go back to our patient, Mr. CC, so I had described to you that he had very active disease. The subtype of psoriatic arthritis that he had was psoriatic arthritis mutilans with axial disease, a number of metabolic and cardiovascular risks. We are fortunate enough to run a multidisciplinary team meeting with our dermatologists. So we're able to make treatment decisions based upon the differences between our pathways. I had mentioned that he had nausea, and also given the non-alcoholic fatty liver disease, methotrexate couldn't really be used. We did trial sulfasalazine briefly for his articular disease. It didn't really work very well, and he had several different topical agents, but we quite rapidly moved towards a TNF inhibitor, adalimumab. And after 30 years, his psoriasis cleared, and he only had 3 tender joints. His visual analog scores improved, and he did achieve the response criteria, the Psa criteria, and a reduction in DAPSA, but he didn't achieve minimal disease activity. I wanted to just point out to you the disease course in psoriatic disease. It was once considered a mild disease, but actually now there's much more evidence that we should be treating early and aggressively, because most people will end up with erosion and damage at 2 years and definitely by 5 years. 18% can achieve remission just with synthetic DMARDs, but most will relapse. And we talked about cardiovascular risk being increased in our cohorts. Predictors of good response, and then vice versa, poor outcomes. Early diagnosis is important. Being a man, people do better. Not smoking, and a good response to DMARDs. Fewer inflamed joints, fewer erosions, lower acute phase markers, and less disability. What factors influence our therapeutic decisions? So as I said, we're just at the beginning of precision medicine. I've talked about some clinical factors here. Severity of disease. Obviously, if people have got severe disease, you probably want to escalate quickly and get them onto a biologic therapy if that's felt appropriate. We want to think about what is the most significant domain affected. Is it the enthesial disease? Is it the skin? And that may result in you choosing a different medication. Prognostic factors, so structural damage is important, especially if people have got erosions at the beginning of when they're seen in clinic. You definitely want to be looking at treating aggressively and early. Comorbidities I've mentioned. Patient factors, so cost, convenience, obviously things such as pregnancy wishes are going to be important. I've only just touched on that here. And I just wanted to sort of finish with an example of, so we've only got one study really, which is this one, looking at a precision medicine approach in psoriatic arthritis. So this is a Japanese study where people have used peripheral blood mononuclear cells and have then characterized T helper 1 and T helper 17 cells based upon CD3 and CD4 surface markers. So these are these little, this is flow cytometry, where they've looked at a marker called CXCR3, which is associated with T helper 1 cells, or CCR6 associated with T helper 17 cells. And then they've used 2 activation markers, CD38 and HLA-DR. And so what they've done is they've then classified patients into 4 groups. T helper 1 dominant, and they've used a 12/23 inhibitor. T helper 17 dominant, they've used an IL-17 inhibitor. A sort of activated T helper 1, T helper 17 high status. So these have got both a combination of T helper 1 and T helper 17s, and they've opted for a TNF inhibitor if it's a major joint, and a 17 inhibitor for major skin, and then a low active status where they've used TNF inhibitors. So this is obviously just one example here, and the outcomes, this is very busy, but one can look in more detail. So essentially looking at a number of different outcome measures using a stratified approach in these patients did appear to improve outcomes. So they've used something called an SDI. They've used a PASI for skin. They've used a DAS28 rather than the 66-68 outcome. And there was an improvement if a stratified approach was used versus just randomly choosing a medication. But obviously this is something that we're not going to be able to use in routine clinical practice. I wanted to point out to you an international study by an organization called Hippocrates. This was an IMI funded study taking place across Europe, looking at unmet needs in psoriatic disease. These unmet needs were defined by GRAPPA and include the identification of patients with psoriasis at risk of progression. We want to diagnose psoriatic arthritis early in patients with psoriasis and in those with undifferentiated early inflammatory arthritis. We want to identify patients who are likely to experience damage and possibly prevent it. And also, we want to look at predicting response to treatment in patient cohorts. So this endeavour is a 5-year endeavour. And I think that the amount of money that was provided by IMI with industry partners was £21 million across Europe to try and achieve these goals. I included the website here, and I'd encourage you to go and have a look at that. Key organisations that I have mentioned to you today: GRAPPA, Hippocrates, ASAS, and the AMP-AIM project is a US-based endeavour, also looking at precision medicine in, well, they initially looked at rheumatoid and lupus, and now the second wave of this project is involving psoriatic disease. And this is where they look at interaction of cells within tissues that cause inflammation and basically new novel targets ultimately. And I'd like to conclude there. I think I've probably run over a little, and I'm happy to take any questions that you may have.
Thank you so much, Carmel. It's nice to see you. And it was a very informative talk. And I think it's very clear to the trainees, at least now, like the rheumatology trainees particularly, that psoriatic arthritis is not just arthritis, it's a disease. Like it involves systemically, and you need to like identify, treat early. And we have a few questions from the audience, Carmen, if you don't mind. So the first question is, ASDAS uses CRP and the BASDA does not. It does not use any inflammatory markers. So do you see a difference in scores due to this?
So, I mean, I think that probably the difficulty with psoriatic arthritis is that quite often, and I don't really know why that we feel that this is the case, people don't often raise an acute phase response, even though they may have quite significant disease. Obviously, in terms of BASDA, in theory, it should only be used to evaluate axial disease. I think if we think about pure axial disease, then probably ASDAS is a more stringent measure for the sort of ankylosing spondylitis cohort or Caspar cohort of patients. So is it important to measure acute phase markers? Well, I think it probably is. If people start off with an elevated CRP, then one can use it as an outcome of improvement. But obviously, if they don't at the beginning, then I guess it's going to be less useful for you. Why people don't raise an acute phase response in psoriatic arthritis, I don't think we've really got a good answer there.
Thank you very much, Carmel. And there's one more question.
Yeah.
Which goes, do you have any experience in using TYK inhibitors in psoriatic arthritis?
So they're not approved in the UK, and I haven't used any in trials. Obviously, I've used JAK inhibitors. So the one that's approved in the UK is tofacitinib for psoriatic disease. So I have got experience of using tofacitinib. In general, the dermatologists tend not to use them very much because the way that the process works in the UK is that often the dermatologists have earlier access to a broader range of biologics than we do. So they're using 23 inhibitors and 17 inhibitors. And obviously we know that 23 inhibitors and 17 inhibitors work really, really well for skin. Probably for joints. I think there's probably now quite good evidence that 17 inhibitors are as good as TNF inhibitors. I guess in terms of 23 inhibitors, they've not been approved yet in the UK, so I haven't used them myself for joints. So answer about TYK inhibitors. So I have seen presentations on the use of TYK inhibitors. My memory from the presentation that I saw by Philip Mees was that possibly was less overall efficacy was less overall good than for JAK inhibitors. Obviously, the concern with tofacitinib, some of you may be aware of this. So there's now obviously a number of different JAK inhibitors. So baricitinib is not approved for psoriatic disease, and it's a JAK1/2 inhibitor. Tofacitinib is a 1/3 inhibitor, which is approved for rheumatoid as well as psoriatic arthritis, and also axial spondyloarthritis. Now, but there has been a recent sort of safety concern with tofacitinib. So we've been recommended not to use it in patients over the age of 65. Upadacitinib is going to be shortly approved for the use in psoriatic disease, and that's a JAK1 inhibitor. I think the jury is out currently at the moment with these different JAK inhibitors, TYK inhibitors. Are we going to see the same safety signals or not, as has occurred for tofacitinib? So I think this is a question that is really unknown. At the moment, the safety data for baricitinib, the 1/2 inhibitor, is looking reasonably satisfactory, apart from herpes virus reactivation. I think things like MACE and malignancy, it's looking relatively reassuring.
Okay.
So I think the answer was no. In terms of the JAKs, I think currently, I don't think that JAKs are looking so promising for skin. So it may be to do with bioavailability in the skin. Obviously, it's difficult to say with you know, obviously, in a way, with the JAK-TYK inhibitors, we're going back to almost being a sort of multi-pathway hit rather than just a single pathway. So the advantages that we potentially get with JAK or TYK inhibitors are persistent, so we're not going to get problems with anti-drug antibodies, and secondly, short half-lives. So if there's a problem, then the short half-life provides an advantage. So these are the factors that we have to balance as clinicians with these particular types of medications. I understand from earlier that JAK inhibitors currently aren't being used in Sri Lanka, was what I'd been told.
Only very limitedly, I would say, like few patients in the private sector I have seen, but like not quite, particularly not in the state hospitals. No, it's not available yet.
Yeah. I mean, obviously, no, that's fine. Another advantage obviously is storage is not such an issue. So cold storage makes them, and obviously they have, so certainly if we think about baricitinib, has really fantastic efficacy in rheumatoid arthritis compared to adalimumab, which is obviously, now there are several head-to-head studies, and similarly I think the head-to-head studies with adalimumab and 17 inhibitors, most of the data really looks impressive for skin, and for joints, I think probably we're looking at sort of similarities. And then the differences are, as I mentioned, with, for example, 23 inhibitors not targeting axial disease, and then the possibility that 17 inhibitors can potentiate or perpetuate inflammatory bowel disease. So there probably is an element that 17 as a medication or as a drug target, there are probably some cells in the gut that produce R17 that are regulatory or protective. So that's where we have differences. Thank you.
Thank you, Carmel. That was so thought-provoking. So I thank you again, and I will now hand over to Dr. Niroshan Lakunarangoda to conclude the session. Thank you so much.
Thank you. Thank you.
Thank you. On behalf of Ceylon College of Physicians, I would like to thank Dr. Stober for very enlightening lecture on this very important topic. It was really helpful. I hope you will be in touch with us in future as well. Thank you, madam.
Thank you very much. It's been a pleasure to give this talk to you today. And yes, as I said, I would encourage any of the young people. I think GRAPPA is an organization which is always looking for new partners and very supportive of young rheumatologists. So I would encourage you to go onto their website, and they've got a fantastic app that you can use in clinic, which includes things like PASI, minimal disease activity measures, as well as Caspar, and opportunities to attend sort of educational meetings virtually, and also submit abstracts and attend. If your abstract's selected, they support you to come to an international meeting. So.
Okay, thank you very much, madam.
All right, thank you. Thank you very much.
And we are grateful to Dr. Duminda Abesinghe, the President of College of Specialists in Rheumatology and Rehabilitation of Sri Lanka, and the College of Rheumatology for collaborating with Ceylon College of Physicians for this month's program. And special thanks should go to Dr. Chaturika Dandeniya for organizing and conducting this session, and especially Q&A session. I should also mention Mr. Nalina and team for technical support. Finally, I thank all of our online participants for your active participation despite your busy schedule. Good night.
Good night.
Thank you.
Thank you.